It's a great pleasure this morning for me to introduce somebody who's going to speak on a topic that's incredibly important to us. And it's Dr. Petros Levounis, who is chair of the Department of Psychiatry at Rutgers and chief of the service at University Hospital in Newark, New Jersey. He came to Rutgers from Columbia, where he served as director of the Addiction Institute of New York and chief of addiction psychiatry at St. Luke's Roosevelt Hospitals till 2013. He's board certified in psychiatry, addiction psychiatry, and addiction medicine. His academic interests include the psychotherapy and psychopharmacology of addiction and co-occurring psychiatric disorders, teaching of psychiatry, gay and lesbian mental health, and the behavioral addictions. Dr. Levounis is a graduate of Stanford, where he studied chemistry and biophysics before receiving his medical education at Stanford and then later at the Medical College of Pennsylvania. During medical school, he researched the effects of social class on patient-physician relationships in Oxford and received an MA degree in sociology from Stanford. In 1994, he moved to New York City to train in psychiatry at Columbia and went on to complete a fellowship in addiction psychiatry at NYU. During that time, he received the American Psychiatric Association Center for Mental Health Services Minority Fellowship, which supported his research on HIV risk factors in homeless men who suffer from severe mental illness and substance abuse disorders. He's written and lectured extensively on addiction topics, has been interviewed by every major national television network, interviewed by every major newspaper in America. He's a Betty Ford Scholar. I'm skipping over the list of all of these. He's a Betty Ford Scholar, a member of the Laughlin Fellow of the American College of Psychiatrists, and a recipient of a 2008 Coalition Leadership Award. And now I'm going to skip over a list of 20 awards that he's won, to say that he has authored or edited 9 books, including the textbook Substance Dependence and Co-occurring Psychiatric Disorders. He's currently working on an American Psychiatric Publishing Pocket Guide to Addiction Assessment and Treatment, and it's expected to be available in 2016. Without further ado, Dr. Levounis.
Thank you so much for inviting me here. As you've heard, I was at St. Luke's Roosevelt for 10 years, where I met Abigail Heron. So now that we are all one family, it is a little bit of a homecoming for me to come and give grand rounds at Mount Sinai. Thank you, Abigail, as well for making the arrangements for these grand rounds. So. What I'm going to talk about today is recovery in mental health and recovery in addiction treatment. And I could have subtitled my talk today, The Serenity to Integrate, the Courage Not to, and hopefully the wisdom to know the difference. In the day and age where everybody's talking about integration, I just want to point out perhaps one area where this integration should give us pause and think perhaps twice before we just go full-fledged into integrating everything. But before starting this part, I just want to fulfill a promise. When we're having breakfast out there, people were talking about the lowest hanging fruit in addiction medicine. What is it that we can really do for our patients? So here it goes. This is my 4-part distillation of wisdom that I've had over the past, I don't know how many years. For alcohol, you send them to AA. Very, very honestly and very forcefully and very sincerely hope that they engage with AA. For opioids, you give them buprenorphine. You absolutely owe it to your patients who are addicted to opioids to put them on the partial agonist on buprenorphine, and I'm delighted to see that Abigail and colleagues are going to be giving training to everybody, and everybody here is going to be certified on buprenorphine. For tobacco, you slap the patch. It's the easiest thing for them. They know about it, and they should do it. And finally, for cocaine and the stimulants, you do need to send them for some kind of psychotherapy, and you do need expert intervention for that. So AA for alcohol, buprenorphine for opioids, the patch for tobacco, psychotherapy for stimulants. That's it. That's all of addiction medicine. We're done. We can go home now. All right. So the way I'm going to do this today about the recovery in mental health and recovery in addiction treatment is we're going to talk very, very briefly about addiction neurobiology, something about addiction treatments, and then we're going to go into the different ideas of recovery before just touching on some efforts to close the gap between recovery in mental health and recovery in addiction treatment. All right, let's start with addiction neurobiology. How do we understand addiction in 2016? From a neurobiological perspective, all of us in this very room, we do have the pleasure-reward pathways of our brain, and they are tuned to tell us, to scan the world and tell us what's pleasurable and rewarding. They live at the mesolimbic system, at around the nucleus accumbens, and they are primarily dopaminergic circuits. Okay? Imagine yourselves right this very minute, nothing too good is happening, nothing too bad is happening. Your dopamine level at the nucleus accumbens is about 100%. If you had a wonderful meal, and no offense to the little breakfast that we've had here, but if you had a real kind of fantastic meal, that dopamine level would jump to about 150% of its baseline. And sex does twice the job of food and would jump the dopamine level to about 200% of its baseline. These are the natural rewarding agents that we all know and love in everyday life. Now, out of 30 million chemicals that we have identified in all of the universe, there are only about 300 of them that have this peculiar ability to go exactly at the very, very same center in the brain and activate the nucleus accumbens in a very, very similar fashion, and thus hijack the pleasure-reward pathways of the brain. That's what addiction is. Ultimately, from a neurobiological perspective, is the hijacking of the pleasure-reward pathways of the brain. You see here that pretty much all these drugs of abuse jump the dopamine level to about 200, 250% of the baseline. Cocaine and, of course, crystal methamphetamine even more so, they do a little more, and they are thus have the extra punch of the dopaminergic surge. All right, so this is the primary engine of addiction happening in the more primitive part of the brain. Once those pleasure-reward pathways have been hijacked by drugs of abuse, they tend to stay hijacked for a long, long time, if not for the rest of the person's life. Let's be very, very careful here. I'm not saying that people do not recover. Quite the contrary. The majority of people who at some point in their lives meet criteria for a substance use disorder will end up beating the disorder. But the vulnerability to go back to using stays with you for a long, long time, if not for the rest of your life. Take an example. Nobody wakes up one morning and says, I want to be a cigarette smoker. It takes several weeks, several months to become addicted to nicotine, correct? But let's say you become a smoker and you smoke 2 packs a day for a number of years, and then you manage to quit. And you quit cigarettes, and you haven't had a single cigarette for 20 years. For 20 years, you're in complete sobriety. As you very, very well know from your general medicine, from the neck down, the body is incredibly forgiving, and your risk for cardiovascular illness and the like starts going down really, really fast. So 20 years into your sobriety, you haven't had a single cigarette, and you have healed to a very, very large extent. So 20 years in your sobriety, you have a few puffs. Something happens, and you have a few cigarettes. Do you expect that it's going to take several weeks and several months to become addicted to nicotine again? Or you're going to go back to 2 packs a day within a matter of days? What's going to happen? You're going to go back to 2 packs a day within a matter of days. The reason for the incredible permanence of the hijacked pleasure-reward pathways of the brain is their geography, their anatomy. Just above and to the side of the nucleus accumbens is the hippocampus, the memory center of the brain. Underneath the nucleus accumbens, and part of the nucleus accumbens, is the limbic system, the center for emotions. Imagine the stronghold of these hijacked pleasure-reward pathways that take on our brains when they're sandwiched between our memories and our emotions. And that is what makes them so darn permanent. Now, miles and miles and miles away from this whole drama that happens down here in the more primitive part of the brain are the frontal lobes. And the frontal lobes, as you very well know, are responsible for rational thinking, for executive function, abstraction, all this good stuff, cognition. Fortunately or unfortunately, the frontal lobes are not very well connected to the pleasure-reward pathways of the brain. Before the age of 25, we feel that not even the cables, not even the hardware is fully developed between the frontal lobes and the pleasure-reward pathways of the brain. I said fortunately or unfortunately because for a lot of functions, it's a good thing to separate our logical thinking from our more emotional center. How do we start understanding the appreciation for the arts or music or sports unless we're able to separate a little bit the frontal lobes from the pleasure-reward pathways of the brain? Even having sex, the whole idea of allowing another human being to enter your body or your body entering another human being is absolutely absurd from a frontal lobe perspective. It is a hugely dangerous activity, and you have to be able to separate that frontal lobe in order to be able to have sex. Now, all this is nice and good until the time when your pleasure-reward pathways have been hijacked by drug of abuse. And at that point, that disconnect is absolutely catastrophic. The whole idea of addiction treatment is try to make some kind of connection so that you can use the rationality of your frontal lobes to cool down the explosive, hijacked pleasure-reward pathways. Ultimately, the war on drugs is a war between the hijacked pleasure-reward pathways and the frontal lobes. And that's how I would like you to think when you have an addicted person in front of you. I want you to think about these two agencies. How strong are the hijacked pleasure-reward pathways versus how strong is the patient's resolve to stay sober? When the hijacked pleasure-reward pathways win, the patient relapses. When the frontal lobes win, the patient is in recovery. The gap between these two agencies gives us a good measure of the stability of the patient's sobriety. That's what we do in addiction medicine. We try the best we can to cool down the underlying engine the best we can and to beef up the frontal lobes so that we can maximize that gap and keep the patient safe. The closer these two things get together, either by awakening of the hijacked pleasure-reward pathways or diminishing of the resolve of the frontal lobes, the closer the patient is at getting relapsing, and eventually, when this balance becomes in the reverse, the patient ends up using. And that simple mathematical kind of construct is really how we see addiction medicine in 2016. Okay? One little footnote that is kind of relevant, and we're going to come back to it, is that we recently have identified motivational circuitry in the brain as well. Meaning, the way that I explained the model before, it's as if the drugs of abuse hijack the pleasure-reward pathways, and the frontal lobes are not really affected. They may be weak, they may be strong, but they're not directly affected by the drugs of abuse. These days, we feel that the drugs of abuse also somehow go in and weaken the resolve of the person, giving a lot of our patients the false sense that they're becoming very, very rational. Meanwhile, it is really the drugs that are talking. The stinking thinking of addiction. The Narcotics Anonymous stinking thinking of addiction. This guy here is very, very rational. If I eat the whole box now, then I won't be tempted later. Makes perfect sense, right? Okay, and that is the neurobiology of addiction. Some bells and whistles, you may have heard about the habenula and the insula and the anti-reward pathways, interoception. There are kind of things that are all related in some way, but basically it's a war between the hijacked pleasure-reward pathways and the frontal lobes, plus the motivational circuitry. Okay, let's move on to a little bit of history of addiction treatment. how have we used some of these ideas or not used them in trying to help our patients? First idea was psychoanalysis. Back in the 50s and the 60s, the one and only treatment that we had available for our patients was psychoanalysis. Put the patient on the couch and hope for the best. Now, what does psychoanalysis do? Psychoanalysis does its best job in shrinking the frontal lobes. That's why we're called shrinks, the psychiatrists, because we shrink the frontal lobes and we allow the more primitive part of the brain to go out there, have some fun, engage with the world, break some rules, and essentially grow. That is a very classic way of the work that we do as psychiatrists. Allow the patient to flourish, cut down on the highly obsessive frontal lobes, and get the person to have some fun in life. Excellent way of doing work. But when it comes to addiction, it is absolutely horrible. Imagine telling an addicted patient, what I want to do with you is to shrink your frontal lobe so that they can allow the more primitive part of the brain to take over. They're going to look at you as if you have 3 heads. If anything, the task is exactly the opposite. The task is to beef up those frontal lobes so that they can possibly take a glimpse at the exploding pleasure-reward pathways and therefore keep the patient safe. So, oops, there we go. So that was a disaster, and that was put aside. By the way, the myth that addiction has no treatment can be traced to the failure of psychoanalysis to really treat our patients. So you're back in the 50s and the 60s, you have only one modality, you deploy that modality, it fails, and therefore your conclusion is that this illness must not have any kind of treatment. Of course, a big mistake, but it lingers, and there are pockets of the population that even in 2016 believe that once you're addicted, you're doomed, and there's nothing that can be done about it. Second idea, boot camps. The Sinai model from California. Let's destroy everything in the brain. Let's break down all the defenses, and therefore we're going to rebuild from scratch. Shaved heads, horrible. These smiling faces kind of reminds us more of a cult picture rather than anything else. Absolutely a disaster. Nobody did well, or the very, very few people who did well actually ended up relapsing. So we're not really happy with the boot camp approach. This led to this idea of the frying pan. Most of you here are way too... So, a lot of you are too young here to remember, but Nancy Reagan came up with the idea, this is your brain, this is drugs, this is your brain on drugs, and basically you fry those eggs, and once the eggs are fried, boom, done. There's nothing that you can do about it, the frying egg analogy. Until we came to the third wave of treatment, the current approach, and the way that we treat addiction in 2016 is essentially based on those 3 modalities. 12-step work, like AA and other mutual help groups, psychotherapy, primarily cognitive behavioral therapy that does this work on the frontal lobes, and medications. Opioids and tobacco, the big success stories of medications, alcohol, so-and-so, stimulants, the big failure of psychopharmacology. And just a couple of ideas here. AA, grossly underutilized among physicians, grossly underappreciated in the medical community. It is probably the most successful intervention that we've had worldwide. There are dark sides to AA, and I'm fully aware of them, and there are some people, quite a few, who may have not done well for AA, and AA is not for everybody, but for a lot of addictions, it is certainly the #1 choice that we have. Cognitive behavioral therapy, an effort to bring together feelings, thoughts, and behaviors. For a lot of us, we engage in behaviors every day that are automatic, that go through channels that do not get informed by our feelings and thoughts, and therefore CBT tries to explain all that, to explicate all that, and help the patient find alternatives. And finally, medications, which you're probably most familiar with, agonist treatments like methadone and nicotine replacement therapies, antagonist treatments like naltrexone for opioids, and now partial agonist things like varenicline for tobacco and buprenorphine for opioids. They certainly have helped us very, very much in the fight against addiction. All right, so that's the lay of the land in addiction medicine, and pretty much we've covered a lot of ground of how we understand and how we treat addiction in 2016. And that brings us to recovery, the title of today's talk. Before these effective approaches were taken by medicine, we were subscribing to that frying pan idea. This is the neurobiological equivalent of it. This is the normal brain. This is the methamphetamine abuser with the colors of life literally and metaphorically being dampened. But thank God with the effective treatments that we now have, we have an appreciation for a three-panel discussion where this is the normal brain, this is the user, and then finally this is the brain in recovery. From a neurobiological perspective, that is what recovery is all about, right here. The return of function in the brain. That is from a strictly neurobiological perspective. All right. Recovery. One of those concepts that means so much and so little all at the same time. There are some terms, there are some universal terms that everybody loves and nobody can ever argue against. I mean, safety in aviation, who's ever going to be against safety or put down crime reduction in mayoral campaigns or world peace? I mean, it's just one of those things that everybody is for world peace. You cannot argue against these things. And these sacred cows have got into our medical terminology, and these are some of the things that nobody can really argue against in medicine. Integration. Everything sounds so wonderful to integrate, to collaborate. Wellness. There are wellness centers everywhere, including us. We're opening a wellness center, and of course, for us, it's going to be a euphemism for a Suboxone clinic, but you know, there are all kinds of wellness things. Harm reduction. All of medicine is about reducing harm. How can you be against harm reduction? Patient-centered treatment, all these buzzwords that we cannot really argue against. And of course, recovery. Everybody loves recovery. Everybody is for recovery. However, when it comes to mental health and addiction, recovery has two very, very different meanings. And to a large extent, as I'm going to argue today, opposite meanings, not just different, but really opposite meanings. We are in the time, 2016, where we are making efforts to integrate primary care with mental health, and we're all for that, and we all support that. My argument has to do not with the integration of primary care with mental health, it's more the integration of mental health with addiction services. And that is where we need to really stop and think twice before we just go full force at integrating everything. Recovery in mental health, recovery in addiction have common goals. And again, it's one of those things nobody disagrees: dignity, meaningful life, personal success, empowerment, and hope. Yes, that's exactly what we want for our patients. That's what we want for our mentally ill patients, and that's what we want for our addicted patients. Mental illness in this context is primarily severe mental illness, schizophrenia, severe bipolar disorder, these kind of disorders. All right, common goals, different paths, very different paths. This is a definition of recovery from the American Psychiatric Association in 2005. Recovery focuses on wellness and resilience and encourages patients to participate actively in their care, particularly by enabling them to help define the goals of psychopharmacologic and psychosocial treatments. The patient is a partner in this process. We empower the person, we get the person to be stronger and stronger and stronger. That is the idea of recovery in mental health. Okay. Sounds good, sounds really good to us. Let's think about addiction. This is the definition, part of the definition of the American Society of Addiction Medicine in 2013. In the spirit of full disclosure, I was in the committee that devised this definition of recovery from the American Society of Addiction Medicine in 2013. The concepts of humility, acceptance, and surrender are useful in the process of recovery. What are we talking about here? Humility, acceptance, and surrender. How different that sounds from this idea of recovery in mental health. Very different. The tone, the overlining concept, the process seems very, very different. Okay, let's break it down some, and let's just see in some specifics here what we're talking about. Here I have a table of mental health recovery and addiction recovery. Let's start with the acceptance of lifelong disease. We talked about the neurobiology of addiction. I talked about the hijacked pleasure-reward pathways being sandwiched between the hippocampus and the amygdala and the limbic system and staying there with you forever and ever and ever. Big part of my everyday work as a treating physician with my patients is to convince them that they are not out of the woods, that you are going to have this monkey on your back pretty much all your life, and you have to be careful about it, and you cannot challenge it, and you cannot really go very close to the danger zones. You cannot really try to see if I can have one glass of wine and maybe that will be okay. Because there's a very, very good chance that it would not be okay, similarly to what we talked about with a person 20 years into her or his sobriety from cigarettes. So we very much encourage the idea of a lifelong disease in addiction medicine, and we are opposed very often by our patients who feel that this is something that happened to me in my 20s and I'm done. Major effort of mental health recovery is to convince people exactly the opposite. You have a schizophrenic patient, everybody in her or his life have told them, this is a life sentence, you will always be schizophrenic, you will never amount to do anything in life, and what we want to do is to empower these people and say, no, this is not a lifelong sentence, there are so many things that you really can do in your life. Powerlessness and surrender, absolutely rejected in mental health recovery. People are powerful, people are self-efficacious, people can really do things. In addiction recovery, it's encouraged. It's number one step of Alcoholics Anonymous. In the 12th step, we give up power. There's something bigger than us and not just our own selves. The issue of humility. Yes, humility is a good thing, but it's not really encouraged in mental health recovery. If anything, we feel that humility tends to make the person smaller. And what we want to do in mental health recovery is to make the person bigger. Of course, humility is a cornerstone of recovery in addiction sense of recovery. Ambition, very, very much encouraged in mental health recovery. That's what we want. We want our patients to become ambitious and fulfill their life goals. In addiction treatment, in addiction recovery, we're a little cautious about that. Ambition, what kind of ambition do you have? To conquer the world like when you were high on cocaine? To go and have this kind of life that you had when you were on crystal methamphetamine? Let's pause here and let's see what kind of ambitions you really have. And finally, autonomy, very much encouraged in mental health recovery and rejected in addiction recovery because people are not autonomous. We used to call 12-step programs self-help programs. This is outdated. This is not PC anymore. Now we call them mutual help groups. Why? Because you don't help yourself. It's the whole group that helps you recover. Autonomy is de-emphasized in addiction recovery. Let me get a couple of very specific examples here. Okay, major slogan in AA. Take the cotton out of your ears and put it in your mouth. Oops, an I missing there. Put it in your mouth. Imagine taking a schizophrenic patient and encouraging them to take the cotton out of their ears and put it in their mouths. The task is exactly the opposite, not just different, but opposite. On the other side, this is something that a patient of mine, in exact words, have told me and meant every word of it. Here, Maria Gold's dog, get loaded and get laid. That's what I want to do with my life. Crystal meth is my best ally in doing that. Do I really want to, wholesale promote these patients' goals in life and ambitions? Is this something that I really want to sign on the dotted line? Absolutely not. All right, so there is a very different ideology, very different meaning of recovery in these two groups. And this is a good thing. I mean, from a neurobiological perspective and from a cultural perspective, the two things are quite different and they need different treatments. I don't know how many of you have been in a pure addiction treatment center, and the feeling that you get in that clinic or center is radically different than what you would see in a mental health clinic. There are graduation ceremonies that they are hair-raising when people get their chips, when people have accomplished their sobriety for a year, for 3 years, or whatever it is that they have managed to do. There are some efforts to close the gap, and we should mention them. We start learning in mental health from the addiction world. Spirituality is probably the most significant one. Mental health did not have much to do with spirituality. It's something that very much lived and still lives in the addiction world. And nowadays, with the issue of mentalization, mindfulness, appreciation of spirituality, sometimes specifically religion, mental health is starting to clue in to that side of recovery. I put down graduation coin ceremonies because this is probably some of the most specific things that mental health world is starting to adopt from the addiction world. In addiction, we start appreciating so much more comorbidity. You go to some of these old school addiction treatment centers, and they believe that there's no such thing as comorbidity. Stop using, stop drinking, and trust me, you're not going to be depressed, you're not going to be anxious, everything is going to be just fine in your life. Your main problem is your use, and once you stop using, everything else will be okay. The major tenement of old school addiction treatment. Of course, we don't believe that anymore, and we do understand that a lot of patients do have comorbidities. Let's not go to the other extreme. There are now people who feel every addict must also have some kind of psychiatric problem. Not true. It is not that comorbidity is not 0% and it's not 100%. It's about 1/3 to 2/3 of addicted patients also have some kind of psychiatric disorder. There is such thing as pure, severe alcoholism without psychiatric disorders. I'm pointing that out because these days we see a lot of punting around. A counselor has a severe alcoholic patient. She or he doesn't know what to do with the patient, and they says, there must be some kind of psychiatric disorder. Send them to the psychiatrist first to check out for psychiatric illness. It may or may not be the case. And finally, the behavioral addictions. We mentioned a little bit the behavioral addictions, things like gambling, sex, the internet, shopping, suntanning. Dr. Heron here is an expert on behavioral addiction topics and has written extensively on these matters. Behavioral addictions lend themselves even more to comorbidity and to appreciation of the mental health side of addiction. All right. Motivational interviewing. Motivational interviewing, as you probably know, is CBT plus or enhanced CBT, especially for people who are highly ambivalent about whether they want to stop using drugs or stop drinking. This is the acronym REDS, the 4 principles of motivational interview for the 2nd edition. Motivational interviewing now is in its 3rd edition, but I like this acronym even better than the 3rd edition. Look at number 4. Oops. Support self-efficacy. Now that is very reminiscent of the mental health type of recovery. And in some ways, it kind of conflicts with AA. We are devising methods of incorporating supporting self-efficacy with a 12-step approach. Of course, there is the whole idea of taking responsibility for your own actions in AA, making amends, and so on. So we are becoming more and more sophisticated in somehow bridging the two worlds. And finally, the systems of care of dual diagnosis. People who do suffer from dual diagnosis, who have mental illness and addiction. we need to provide integrated treatment for these patients. And let's just look at this, this diagram here, which is the last slide for the talk. On the x-axis, we have increasing severity of psychiatric disorders. On the y-axis, we have increasing severity of substance use disorders. So primary care primarily is, primary care lives on quadrant 1. And we do hope that we'll have integration of mental health and addiction services when it comes to low levels of psychiatric disorder and low levels of substance use disorders. This here is mostly mental health clinics, severe mental illness with low levels of addiction. Number 3 is the addiction centers. That's where you have severe addiction with low levels of psychiatric disorders. And number 4 is very often called no man's land. That is where we have severe mental illness and severe addiction. And despite our best efforts, we really do not know how to address quadrant 4. It continues to be, even in 2006, probably one of the biggest challenges in the world of mental health and addiction. My talk today covers very much the quadrant 3. What I'm saying here is that people who suffer from severe addiction may be better served in addiction culturally and financially and in several different ways, centers that know how to do addiction treatment, that subscribe to the different culture of addiction recovery, and not to be wholesale integrated with pretty much everybody else. All right, that's it, a couple of conclusions. If there's one take-home message here I would like you to take, is that recovery in mental health primarily focuses on promoting the patient's ego, psychiatric language, for promoting the person's sense of self, of expanding the person. Recovery in addiction medicine and addiction treatment focuses on containing the ego, on cutting down the person a little bit, of reducing this kind of exuberance about the drugs, helping the person with having somewhat increased humility in front of a devastating illness like addiction. So, yes, we applaud all these efforts to exchange ideas and to learn from one another and to somehow bridge the two worlds, but that does not necessarily mean that we should integrate everybody without much thought behind it. Thank you very much. And we do have 10 minutes for questions.
Thank you. That was great. So I have 2 questions. One is, I've had patients who, once they recover, are so upset and frustrated with the reality of their lives that they say, if this is sobriety, I don't want it.
Yeah.
And it sort of leads to, I guess, a question about 2 other dimensions that you might address. One is the social determinants of health. Mm-hmm. And the fact is that people often descend into problems with addiction because of external factors of poverty, of failed relationships. And I guess specifically talk a little bit about family systems and family therapy in the role of addiction, and the importance.
Wait. Too many things. I can't even remember the first question now. Okay, well, one thing at a time. The first part was that people sometimes are just so, they realize all the losses that they've had before. The life in sobriety is not what was cut out to be, and so they're very disappointed by that. That is true. We do see that. We certainly see that with crystal methamphetamine, which we've had a lot of experience with in New York City, when people say that simply sex is not the same. It's a wonderful, wonderful article that came out in January of 2016, the aftermath of sex. The aftermath of sex, just basically saying how impossible it is to have sex again with the same level of intensity once you're sober from crystal methamphetamine. Very true. Some kind of timeline here. In general medicine, you have the rule of 3s, 3 minutes without oxygen, 3 days without water, 3 weeks without food before you die. In addiction medicine, we also have the rule of threes: 3 days for the acute withdrawal, 3 months for the protracted withdrawal, and 3 years to achieve some kind of stable sobriety. So do expect that, especially in that middle part, first of all, the 3 first days can be absolute hell when somebody's withdrawing from opioids or sedatives, benzodiazepines, alcohol, and the like. But pay attention to the 3-month mark as well. This is the time of protracted withdrawal. People feel miserable, irritable, anxious, and that is the time where a lot of disappointment happens. After 3 months, people start rebuilding their lives and things get better. In terms of this idea that addiction is primarily a social disease, I think that we should go back to very, very basic idea of the biopsychosocial model. There's very strong genetic component of addiction. There's a strong psychological component in terms of self-medication of untreated psychiatric disorders, but also a very, very strong family component, environmental component. And so I think that addiction is the prototypical biopsychosocial illness. You don't have to have vulnerabilities in all 3 of these matters. One of them may take precedence over the other ones, but we do appreciate biological, psychological, and social forces that cause addiction. A little bit of a footnote here. The addition over the past few years has been that even in the absence of any biological, psychological, or social vulnerabilities, the person can get very, very addicted as well. Let me just stop here for a minute. In the past, we used to think that if the patient does not have a genetic load, is not psychologically burdened, meaning does not have any kind of self-medication of anxiety, depression, and the like, and they are not living in a drug-infested environment, the risk of addiction is minimal. Where did we learn a lesson about that? Prescription opioids, the prescription opioid epidemic. Very, very big part of it was our false belief as physicians that if the patient does not have these biopsychosocial vulnerabilities, we could prescribe very, very safely as high a dose of morphine as possible and nobody will get addicted. Well, think again. The vast majority of people who get addicted to addiction opioids do not have these biopsychosocial vulnerabilities. They simply got high-dose opioids from a physician who didn't know what she or he was doing and end up being addicted. So now we're thinking of the biopsychosocial model plus the use of the drug itself as a major component of addiction. Thank you.
So,
warms my heart.
Really amazing.
Thank you.
So thank you very much. I just wanted to ask you if you would speak a little bit about marijuana, because it's on everybody's mind. It's on everybody's mind. You didn't really mention it at all, and yet we see a lot of people who are chronic users. And what is the impact, and what do you do with folks like that when it affects their life?
Okay, where to start with that? Okay, first of all, marijuana of 2016 is not the marijuana of the 60s. We all know that. The percentage of the THC, of active ingredient in marijuana, is over 12% in 2016. It used to be like 2 or 3% back in the 60s. So we're talking about a little different beast. Plus the synthetic cannabinoids. When you think about spice and K2 and the like, they're much more potent. They do not have the beneficial effects of cannabidiol. When you smoke marijuana, natural marijuana, you do get all the THC effects in terms of becoming psychotic and the like, but you also get the antipsychotic effects of cannabidiol, and you tamper this kind of dangerousness. When you have the synthetic cannabinoids, you are deprived of that cannabidiol effect, which seems to be the most important component of the beneficial effects of marijuana, and that's why synthetic cannabinoids are so much worse. No question that cannabis does have therapeutic properties. I don't think there's anything new about that. When I was an intern 100 years ago, I would prescribe Marinol, synthetic tetrahydrocannabinol, and we all knew about that, and that was perfectly fine. It has analgesic properties, it has anti-nausea properties, maybe perhaps for glaucoma, different kind of areas. The issue here is a cost-benefit analysis, and there is very little doubt in 2016 of the significant adverse effects of cannabis the addictiveness of cannabis itself and the long-term problems that it gives in terms of cognition and perhaps motivation as well. So yes, there are patients of ours who are fully addicted to cannabis, and we can help them. Motivational interviewing seems to be one of the best ways to go with cannabis. Why? Because the majority, it's fascinating. With tobacco, the majority of patients who come to us with tobacco problems are fully resolved that they want to quit. The majority of people who come to us with marijuana problems do not feel that they have any problem with it. So they're both smoked products, and yet the motivation to change is very, very different. That's why for cannabis, we go more the motivational interviewing path that, as I said before, is particularly good for people who are either ambivalent about their use or they do not want to change anything in their lives. Remember, before motivational interviewing, we physicians, we used to say to our patients, the horrible, horrible thing, come see me when you are ready. I've got nothing to offer to you unless you are ready to change. Thank God with motivational interviewing, you can start working with people way before they're ready to change, even in the pre-contemplation stage of change.
First, let me say, always a pleasure to attend one of your presentations.
Thank you.
I wondered if you could discuss a little bit more about efforts to blend, I won't use the word integrate, the support self-efficacy level of motivational counseling and more traditional 12-step concepts such as humility, surrender, so forth.
Yeah, I think that I would draw, once again, from the AA tradition. If you go to any AA meeting, you're not going to hear much like, oh, too bad, you got this disease, therefore there's nothing that you can know about it, it's like cancer, and so, you know, you're home free. Quite the opposite. Lots and lots of personal responsibility. Yes, you're powerless over the drug, but what are you going to do about it? So that's the path that we're taking with a lot of our patients when we're trying to bridge the motivational interviewing approach of self-efficacy with AA. The difference there is that you cannot do it alone. Don't think, it's kind of the Munchausen who is trying to pull himself with his own hair. You cannot do that. You can believe in God or not believe in God, but you have to believe in something larger than yourself, whether it is nature, community, your family, something outside so that you can take some of the burden from your shoulder and put it on somebody else. And that's where I would go in order to reconcile the self-efficacy part with the powerless and surrender. Yes, you will have this vulnerability for the rest of your life. What are you going to do about it? In some ways, people who have trained in pediatrics or child and adolescent psychiatrists have a leg up on us adult people when it comes to this apparent paradox. They can resolve it very, very easily. Yes, you have that, but you're responsible. Go ahead.
So at the beginning, you mentioned the 4 pillars, and you said for heroin, you said Suboxone.
Uh-huh.
But we mostly encounter, at least I've seen, mostly methadone, and you kind of didn't. I was wondering your thoughts on like methadone clinics and how we should approach patients that come in on methadone.
Okay, methadone, wonderful medication, has helped literally millions of people around the world. But in 2016 is not our first-line treatment for opioid use disorder. The first-line treatment is buprenorphine, and unless you have a particular reason why you're not going to be using buprenorphine, then you should really prescribe buprenorphine. It has less side effects than methadone. Most importantly, you cannot overdose on buprenorphine. Our friend Ed Salsitz, who is a faculty of your school right here, says methadone doesn't have a sense of humor. And he's absolutely right. You screw up on the dose a little bit of methadone and you end up killing your patient. You cannot do that with buprenorphine, a huge advantage. You can prescribe buprenorphine out of your own office. The patient, in her or his own privacy, can take a prescription, fill it at the pharmacy, and go home and take their pills. So huge advantages of buprenorphine over methadone. Methadone continues to be very important. Several people will do better on methadone than buprenorphine. Pregnancy, it's still out there. We know that the neonatal abstinence syndrome is much better if the mother was on buprenorphine than methadone, but we're not so convinced that for the mother herself, buprenorphine is better than methadone. They're probably about the same. So there's some sophistication in that matter. In general, buprenorphine is our first-line treatment.
On that note, so in our clinic, we get a lot of patients, or some patients, I should say, who are engaged in methadone treatment. And it becomes very difficult to engage with them in a primary care setting just because we're trying to engage them in a different way and accomplish some primary care goals and things like that. A lot of times they're heavily sedated, and it presents a really big challenge. What do you suggest in those cases? Who can we talk to? What are some resources? Any guidance would be appreciated.
The best way to do this would be to partner with a methadone clinic so that you can switch the patient from methadone to buprenorphine so that you can prescribe the buprenorphine along with whatever else you are prescribing for the patient, so have all the patient's care under one roof. Unless it's one of those other situations that I talked before, like somebody had great success with methadone in the past or are allergic to buprenorphine or something like this, try to switch them from methadone to buprenorphine. Also, a huge resource that you guys have here is Abigail Heron, an expert on buprenorphine and all these matters. You know, tap on to her. I'm volunteering you here, Abigail, for these matters. But basically, the answer there would be to switch them from methadone to buprenorphine and have everything under one roof. All right. I promised people that I'm going to let them off at 9 o'clock because I know. Oh, one more? Okay. All right.
I know you said addiction is a lifelong disease. However, like, is there ever an endpoint for our treatment to remove any sort of substance for these patients?
Absolutely. The substances themselves can be ended. And as I said, the majority of people live in sobriety. They've quit smoking. They don't drink anymore. So there is an end point in terms of treatment. And when I said the rule of threes, after 3 years of having attended AA or having been in treatment, and if everything tells you that there's a stable sobriety with good psychoeducation, you can actually discontinue treatment of the patient, and the patient can most likely will go ahead and live a happy life. It's the vulnerability that goes back, that stays with you. And I'm very careful about how I phrase things. I say, for a long, long time, if not for the rest of your lives. We're not sure about that. There could be extinction. After 20, 30 years of sobriety, perhaps the pleasure-reward pathways are not hijacked anymore, and they have returned to absolute normal. And there's some neuroimaging data to suggest that no matter what, it is not a matter of weeks, it's not a matter of months, it is not even a matter of years. If there is extinction of that hijacking, it will be a matter of decades. That we're very, very sure about.
Well, thank you very much. Let's give a good round.
Thank you.
Really excellent. Thanks.